Thank you so much, Nonadis people, Hamid and Syed, for giving me the opportunity to be the speaker of this evening. I am Dr.Sepuri. I am an endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Karnool. So, today we are talking about this is a new series we have started, the master class in insulins. So today I am going to talk about revisiting the insulin landscape and understanding the clinical benefits of new generation insulins. And very good evening, my dear professional colleagues. So I welcome you all to this scientific sessions, the master class in insulins. So I request all the participants to type their questions or queries and in the chat box so that I'll take up all the questions at the end of the session, that is after the second speaker completes her talk. With that, we just move on to this. And this is my financial disclosure. And today's agenda is divided into like three parts: leaps of innovation in insulin development, followed by determining the choice of therapy for insulin initiation, and the last part being two-in-one solution, innovation that suits best to Indian reality. And according to MacLeod, and not actually Campbell, it is MacLeod. See, the discoverers are, it is James Collip actually. See, the four people who were involved in the discovery of insulin, we should never forget that the first and foremost man is only Grant Frederick Banting, who did everything actually, who deserves the entire honor. So, along with Charles Herbert Best and along with John James Rickard MacLeod and along with James Bertrand Collip actually. So Banting and Best, MacLeod and this particular Collip, they said in 1925 in using insulin it would be, of course, be ideal if it could be supplied so as to imitate the natural process. So Campbell is there in the scene actually, but Campbell is the physician actually, the chief physician, who has given the crude extract that was prepared by Grant Frederick Banting for the first time in the world to a 14-year-old boy called Leonard Thompson actually, who was about to die actually with the DKA. So the 15 ml of the crude extract, he made it into two parts and he has injected 7.5 ml into each buttock of Leonard Thompson. So that way Campbell is important, but he is nowhere related to the discovery of insulin. Even the J.J.R. MacLeod, who was the professor and head of the Department of Physiology, was nowhere related to the research aspect because it was all done by the orthopedic surgeon. Very surprisingly, the innovation of insulin, the discovery of insulin is very interesting, and I'll ask these people to have another session just purely on the discovery of insulin, which will be very interesting, and I think everybody should remember this actually, how it was discovered and what are all the controversies and who were prior to Banting, the MacLeod, Best and Collip, like in way back in 1889 itself, Von Mering and Oskar Minkowski, the doctors from Germany, they found out that the pancreatectomized dogs developed diabetes and died within soon, like within 1 week or so. So that has led to the greatest mystery in the world, that something is related. The pancreatic substance has got something which controls the glucose metabolism. So they just called it as insula. The insulin word has come from the Latin word insula, which means an island. That is from the islets of the Langerhans Islands. So that is the history prior to this, and that made this young orthopedic surgeon, the Grant Frederick Banting, to go for the discovery of insulin actually, which is a revolution in the history of medicine. And he discovered it at the age of the very young age, like 23 years. And later on, in 1921, he prepared the crude extract, and which was purified by Mr. James Collip actually, who was a biochemist. And the Nobel Prize was awarded in 1923 to Mr. Grant Frederick Banting and the MacLeod, who did nothing, but he was entitled to receive this thing because he is the one who gave 10 dogs and a whole lab for this particular gentleman, Grant Frederick Banting, a young orthopedic surgeon. So that was the history. And then Grant Frederick Banting was not happy with the decision of the Nobel Prize to share with alone this thing, because there are another two more like Charles H. Best and as well as the James Collip were there. And he said, I am not going to accept this prize unless until it is shared with Best. But as on records, the Nobel Committee did not recognize Best as a Nobel Prize recipient. But Banting magnanimously shared his prize amount with Best, and forcibly MacLeod unintentionally shared his the amount, half of the amount, to Mr. James Collip. So with this, we come to this real topic, and you can see in this slide how the evolution of basal insulins has happened. You just go back to 1946, that is neutral protamine Hesdan, that is 1946, and year 2000 Glargine U100 was discovered, and then 2005 the Detimer, and the 2013 the Degludec, and 2015 it is Glargine U300. And you start from this particular the NPH insulin. So the plasma half-life of NPH insulin is 5 to 10 hours. The T1.5 is nothing but the plasma half-life. That refers to the time required for plasma concentration of a drug to decrease by 50%, and the T1.5 is dependent on the rate constant, that is K, which is related to the capital V and the small d and the clearance, that is the CL. So the NPH, the plasma half-life is 5 to 10 hours, and the Glargine U100, it is 12.5 hours, and the insulin Glargine U300, it is 17 to 19 hours. And if you notice, the Degludec has got the longest plasma half-life of 25.5 hours. So coming to this NPH and later on to the insulin Glargine bar Detimer, it is either to be taken once or twice a day dosing, and relatively a flat pharmacokinetic profile and lower variability. Whereas when we take this particular insulin Glargine U100 to insulin Glargine U300, less diurnal variation, and it has got lower peaks and longer duration of action, that we have seen from insulin Glargine U100 to U300. The plasma half-life is 12.5 for this insulin Glargine U100, whereas 17 to 19 hours is for insulin Glargine U300. I'm getting some echo.
Sir,
Please, please. Yeah, when we come to this particular, from we switch over from insulin glargine U300 to insulin deglutec, and you can find that this is the one, the deglutec, insulin deglutec has got the maximum plasma half life of 25.5 hours. That is, it's the ultra long acting basal insulin with 80 to 40 hours of flexibility. So the more the flexibility, any time of the day you give, that is very effective, and with a very lower variability and less dose requirement. These are the advantages of the insulin deglutec over the NPH or the detimer or the insulin glargine 100 and insulin glargine U300. And let us come to the evolution of the prandial insulins. So we talked about the basal insulins, and now we see this diagram shows us the evolution of the prandial insulins. Way back in 1922, the short acting first clinical use of insulin, I told you Leonard Thompson was the first patient in the world who was a type 1 diabetes patient, aged around 14 years. He is from Toronto. So this research of insulin was, everything was done in the University of Toronto, where these 4 people were involved, I said. And the first clinical use was used by this particular Campbell, that is Walter R. Campbell, in 1922, and the 1980 the biosynthetic human insulin, that is what we are using nowadays, that is the genetically engineered rDNA human insulins that we are using extensively in our country, that was evolved in 1982. And later on in 1997, insulin lispro came into vogue, and insulin aspart in 2003 respectively, and the exubera inhaled insulin was in the year 2006, but unfortunately it was withdrawn by US FDA a year after the discovery. And 2015 the Afreeza inhaled insulin was introduced, and 2017 the ultra fast acting, the faster aspart 2017, that was the FIAS, what we call the fast acting insulin aspart. So when you come to this particular the glulysin, so which was in the year 2002, actually, the short acting analog short acting insulin prandial analog in 2005, the rapid acting insulin analogs versus the regular human insulins, you can find on the left hand side that the advantage is increased monomeric fraction and the permeation rate and the greater early glucose lowering effect and improvement in HbA1c. And coming on to the right hand side, you can see that the faster aspart, that is fast acting insulin aspart, that has got the characteristics like it closely mimics the physiological mealtime insulin secretion, and a better control of both 1 hour and 2 hour postprandial glucose control. And a better control of both 1 hour and 2 hour postprandial glucose control, and flexible dosing to 2 to -2 to +20 minutes, and significantly lower risk of overall and nocturnal hypoglycemia. You can see with this fast acting insulin aspart. Slides are not moving. Now you can see the evolution of premix insulins. We have seen the basal insulins, we have seen the prandial insulins. The mixture of basal and the prandial insulin, that becomes the premix insulins. And the advancements we can see, like in 1921 the isolation of insulin, and the 1973 monocomponent animal insulin preparations, that is ultra pure. And in 1980s we can see the recombinant human insulin, that is biphasic human insulin, that is which consists around 30% of regular human insulin and 70% of NPH. And also the 2000 it is Lyspro mix, that is 30% plus 70%, and again 2001 it is biphasic insulin aspart, the same thing, the 30% of insulin aspart and the 70% of protominated insulin aspart. And likewise in 2013 the co-formulation has come actually, that is the 30% is the insulin aspart and the 70% is insulin degludec, which is otherwise called as the co-formulation, first of its kind in the world. And as of now this is the only one co-formulation we have. So the advantages of the recombinant human insulin, see, that is that controls both fasting plasma glucose and the postprandial glucose, and it is simple and convenient. You can either dose it as once a day or twice a day, that is either OD or BD. And the disadvantages are lack of mealtime flexibility, because it has to be taken half an hour prior to the meal, and opportunity for better PPG control and lower hypoglycemia risk. And you take this the premix analogs, they have the mealtime flexibility, and they are more effective at reducing PPG than the when compared with this biphasic human insulin 30. And the importance of the reductions in the postprandial glucose is the normal fasting with increased PPG is always associated with the future cardiovascular disease. So this is evidenced by the 7 major studies, which includes the landmark study, the Honolulu study. So I don't mean to say that you can neglect fasting and only control PPG, because both are important. Fasting is equally important and controlling PPG is more important, because keeping the future cardiovascular disease in view and the lower risk of hypoglycemia when compared to the biphasic human insulin. So the biphasic premixed human insulins, in one way they are very much like the premix analogs are very superior to this biphasic premix human insulins, and the opportunity for better fasting plasma glucose control and lower hypoglycemia risk. And when you come to this co-formulation, you have all the advantages like better fasting plasma glucose reductions and lesser risk of confirmed or nocturnal hypoglycemias and lesser insulin dose requirement. So these are the differences between the different the premix insulins, what we have seen from the regular the human biphasic premix to Lyspro mix, as well as the biphasic insulin aspart and the co-formulation, the insulin degludec and aspart. And coming to the second part of the agenda, determining the choice of therapy for insulin initiation. And this slide shows you the, like, you can understand the insulin formulations meeting the individual needs of the patients. On the left hand side you can see the exogenous insulin, that is inside the bottle, and the inside the like, as long as it is outside the body, and it is inside the either the bottle or this particular the refill or the pre-filled flex touch pen. And on top you see the endogenous insulin, which is that is present in the human pancreas. And the endogenous insulin is like the moment you take the meal, this it starts functioning, and the beta cells they release the desired quantities of insulin and using the target cell. Whereas the exogenous insulin, it is active only when it is injected into the subcutaneous tissue. Usually the abdomen is the site for injection, that is subcutaneous injection of insulin. Once it is injected into this subcutaneous tissue, and it breaks into the dimer and the monomer, and that happens in the subcutaneous space, and that gets into the blood capillary, and then it starts functioning. So this is the difference between the exogenous and the endogenous insulin. And on the right hand side you can clearly see that the breakfast, lunch, dinner on the x-axis, and the plasma insulin levels on the y-axis. And on the down you can see this the graphic representation, whereas the first one shows the purple shows the rapid acting analog insulins, that is Lispro, Aspart and Glulysin, and the second green shows short acting insulins, the human regular insulin, and the third one light blue is intermediate acting human insulin, that is NPH, and the long acting black analog insulin is Detimer, and the next one is long acting insulin, that is Glargine, and next is the long acting analog insulins, that is U300 Glargine and Deglutec. And you can clearly see the peaking stage, and it falls down, whereas this particular U300 Glargine and Deglutec, they have a steady phase, like there is no peaking, and that's also the no up and down in the blood sugars, which results in very less incidence of the hypoglycemia, and a very steady state of euglycemia is well maintained with this the Deglutec and the Glargine 300. The time action profiles of insulin and the formulations have been intentionally modified to more closely mimic the endogenous insulin response. The clear funda behind giving the insulin therapy, that is the combination of basal and the prandial insulin, is always we should try to mimic the natural, the physiological insulin secretion, what is done by this the beta cell of the pancreas. We try to mimic that, so that the basal component is the one that is permanent, that 1 to 2 units an hour is released constantly in the body, whereas the prandial component, whenever you take food, the breakfast, the lunch and the dinner, and accordingly the pancreas releases the required amounts of insulin corresponding to the food you take. So our aim is that we should closely mimic the normal, the physiological secretion of the insulin by the beta cell of the pancreas. And the conventional insulins and the challenges with its use. See, on the left hand side you can see the NPH insulin. It is insufficient basal insulin coverage, need for multiple injections. At least NPH has to be given twice a day, because the plasma half-life is 5 to 10 hours, and that needs for resuspension. It has to be resuspended before the use, And significant day-to-day variability you can find with this particular NPH insulin. And on the right hand side, coming to the biphasic human insulin, that needs to be injected 30 minutes before the meal, because I always tell in my insulin lectures, actually this is a masterclass insulin lecture. So the biphasic premixed human insulins, that is you know the brand names, so I don't need to mention the brand names, I'm not supposed to also. So this, as long as it is in the bottle, it is in the inactive form, and it is in the hexameric form, and once it is injected into the subcutaneous tissue, the hexameric insulin becomes the dispersing into a dimer, and a dimer again breaks down into a monomer, and the monomeric insulin is the active principle of insulin. So the breakdown from hexamer to dimer, dimer to monomer, that is the active principle of the insulin, it takes around 30 minutes. So that is the reason why we always give the human biphasic premixed insulins half an hour prior to meal. And second thing is the greater risk of hypoglycemia and the opportunity for better PPG control. This is an advantage with this, and it's a poor fit to patients' lifestyles, because different patients have different lifestyles depending upon their profession and the work style, the meal time, the daytime duty or the nighttime duty. So it is like it poorly fits into the patient lifestyle profile. And comparing basal analogs versus the conventional human insulins, and on the left hand side you can see the analog basal insulins versus the NPH insulin. The advantages you can see, the analog insulin, basal insulin, is longer in duration of action, and it has got more predictability and less hypoglycemia, especially the nocturnal hypoglycemias, which are very, very important, and a favorable effect on weight, and a lower risk of emergency department visits or hospitalizations for hypoglycemia. That is always a cumbersome procedure, and that is an additional burden on the patient and an additional load on the hospital, that is the staff as well as the healthcare providers and as well as the healthcare professionals, that is the doctors and the paramedics. And this particular the comparison is done with the Detimer versus NPH. The basal analog was Detimer, and it is compared with the NPH on the left hand side. And on the right hand side you can see the bar diagram, which shows on the y-axis it shows the mean glucose infusion rate area under the curve 24 hours, that is milligram per kilogram per minute. And on the this thing you can see this the x-axis, the blue is that represents the NPH, and the middle one that represents the insulin glargine U100, and the last one dark blue that represents insulin Detimer. You can very clearly see that the upper this thing is it is 2 times more than the mean glucose exposure, and it is the middle one is the mean glucose exposure, and the last one being the 0.5 mean glucose exposure. And this shows that the lesser variability of the first generation basal analogs. And according to the ADA 2022 standards of the medical care as far as diabetes is concerned, the guidelines, the recommendations as far as the diabetes is concerned, the basal insulin analog with lower risk of hypoglycemia should be considered. That is, see, the degludec is superior, degludec or the insulin glargine U300 are superior to Detimer or the insulin glargine U100, and they are very much superior to NPH. So the least priority to NPH, that is always a poor man's choice. And next is the Detimer and the Glargine U100. And the best part is the insulin Glargine U300, and the best is Degludec. So this is the comparison of premix analogs versus the conventional human premix insulin. The analog premix, which is the biphasic aspart 30 with the biphasic human premixed insulin. The advantages of this premix is you can find this biphasic aspart, the faster absorption, the higher peak concentration, more rapid and pronounced glucose lowering effect, similar duration of action of a basal component. And on the right hand side you can see this diagram, which and to the left hand side that favors the biphasic insulin aspart, all the trials, and on the right hand side that favors the biphasic premixed human insulin 30. So you can see the trials, multiple trials, that is Bohm et al. In 2002 and Kilo et al. In 2003 and Iwamoto in 2003, and a study called 1394 and McNally et al. In 2007 and 3000 bioequivalence trial. So this all shows the greatest advantages of this particular the biphasic insulin aspart 30, that is that significantly the lower rate of major hypoglycemia compared with biphasic premixed human insulin 30. So you can see everything is favoring this particular biphasic insulin aspart 30. So the multiple the trials with the backed by the evidence based medicine, you can just clearly say that this particular the biphasic the insulin aspart 30 significantly has got a lower rate of major hypoglycemia when compared to the biphasic human premixed insulin 30. And this graph diagram shows the value of insulin analogs in the management of type 2 diabetes mellitus. So the dark blue line is human insulin and the orange is analog insulin, and you can see the HbA1c on the x-axis, and on the y-axis you can see the annual rate of non-severe hypoglycemic episodes, and you can very clearly see that it is very much less. The analog insulins have shown the very less incidence of hypoglycemias when compared to the human insulins. The preferential use of analog as opposed to human insulin has the potential to promote better glucose control and reduce the burden of hypoglycemia. This is the inference from this graph. And now determining the choice of therapy for insulin initiation in tune with the key realities of management, the managing diabetes in our country, India. And this is a colorful slide. You can see the high carbohydrate diet is a common Indian reality. See, whether you take the central part of India, whether you take the southern part of India, whether you take the northern part of the India, whether you take the western part of India or the eastern part of India, which is divided into 5 parts, wherever you go, the average food contains at least 60 to 70% the meal consumption is carbohydrates, and that is the major culprit in our country actually. So coming to the left hand side, actually the pure study, the white rice intake and incidence of diabetes, if you take the first one is the overall, and the Europeans, you can see the least is with the Europe and Africa and South America and the Middle East and the China, and it slowly increases. See, from see, first one is overall, okay, that is fine. Whereas we start with Europe, which is the lowest, and Africa, slowly there is increase in the incidence, and again South America, and followed by Middle East and China and Southeast Asia, and the highest is seen with this South Asia, that is the India and the Pakistan. That is the reason why China is heading the world, that is the world capital city of this particular diabetes is China, standing on the list, the number one place. And until 2012, we were in the number one place as far as this WHO is concerned, that accredited India as the diabetes capital city of the world is India. And now India is in the second place, and the US, the United States of America is in the third place, and the Pakistan is in the fourth place. And we all, the clinicians, the primary care physicians, whatever it may be, the diabetologists or the endocrinologists, whoever is treating diabetes, we are striving hard to make this diabetes capital of the world into diabetes care capital of the world. So, in the overall cohort, higher intake of white rice was associated with increased risk of diabetes, and however, the highest risk was seen in South Asians. See, I said this particular the three countries, the India and the Pakistan, and coming to the and adding to this one scientific input, I just have to put it to that. Not only the intake of white rice along with potatoes, that too fried potatoes, especially the potato chips and the finger fries, that is the French fries, they are associated with the increased incidence of diabetes. That is what is happening in our country. Apart from the familial tendency, the genetic preponderance, the worst culprits are the white rice and the consumption of potato. And coming to the right hand side, that is starch study, the dietary survey in Indian type 2 population, the 61 to 70% of energy intake in India is through carbohydrates that is present in the diet. I said, you take any part of the India, the average carbohydrate content is around 60 to 70%, and that should be curtailed to, what I mean to say, the balanced diet should be like, every time I say the plate should contain 40% of the carbohydrates and the 30% of proteins and 30% of fats. That makes things very easy. And if you start eating 40% of carbohydrates with more of protein and more of this thing, oils are also very, very important and for the body. So with that, we can see the decline in the incidence of diabetes. And the high carb diet leads to the raised postprandial glucose levels. I said earlier, all the time the culprit is the high carbohydrate, which leads to the increased postprandial glucose levels, which is associated with the increased risk of cardiovascular disease. The 7 major studies I said, out of all, the very prominent is the Honolulu study. Yeah, you remember that the normal fasting and the abnormal postprandial always is a future indicator of the cardiovascular disease. Please try to prevent that by controlling the postprandial glucose as well as the fasting plasma glucose, and maintain an A1C, that is the glycemic triad. And again I tell you, now it is not sufficient if you just maintain diabetes. You have to all the time remember ABC or the HDL. I always tell this in every of my speaker programs. The A stands for A1C, B stands for blood pressure, C stands for cholesterol. If you don't control all these 3 parameters, likewise HDL, the hypertension, diabetes and lipids. If we don't control all these three, we are not able to control either the microvascular complications of diabetes or the hypertension, or the macrovascular complications of the hypertension or the diabetes. So unlike the Western population, the postprandial plasma glucose should be controlled at all levels of HbA1c in Asians. And on this is a bar diagram showing the x-axis, the HbA1c quintiles you can see, and the contribution on the y-axis you can see, and the blue one stands for the postprandial glucose, and the grey bar stands for the fasting plasma glucose. This is I am talking in particular the Asian picture, and the data from Monier et al. It says higher contribution of postprandial glucose at lower HbA1c levels, similar to the Caucasians. So the same Monier et al. The data says the significant contribution from FPZ, the PPZ, even at higher HbA1c levels in Asians, unlike the Caucasians. You can very clearly see that they all the time the A1C less than 7.1%, and it is the second bar diagram is 7.1 to 7.5%, and the third one is 7.6 to 8% of A1C, and 8.1 to 8.7% correspondingly, and the 8.8 to 12.7 respectively. All the time you find almost an increased postprandial glucose and an increased fasting plasma glucose, so which is to be the meticulously controlled at all levels in all the Asian population to control the risk of the microvascular or the macrovascular complications. And addressing the key realities of managing diabetes in India, the determining the choice of therapy for insulin initiation, the high baseline PPG value in type 2 diabetes mellitus from India versus others, and the various factors you can see. The question is which insulin regimen can address all these. All the problems are the Indians with the left hand side you can see Indians with typical Indian Asian phenotype, that is high waist circumference, and I think you are all aware of the waist circumference. In males the cutoff is 94. If it is more than 94 centimeters in males, it is considered very pathological, and in females 80 centimeters, beyond that is very pathological. And higher total and visceral fat, and hyperinsulinemia, and likely the insulin resistance. See, insulin resistance is the key background pathophysiology in the Indian population of the patients suffering from this the type 2 diabetes mellitus. I don't say that insulinopenia is a problem, but more than insulinopenia, insulin resistance plays a vital role in Indian population. So insulin resistance is always at the level of liver, muscle and fat. And high intake of carbohydrates that leads to higher glucose excursions after every meal. And the high baseline PPG value in type 2 diabetes from India versus others. And on the right hand side you can see the delayed initiation of insulin therapy and the higher risk of failure of basal insulins, and need for simple and convenient insulin regime, that is the regimen, the intensification, the treatment with same insulin. So now the $1 million question is which insulin regimen can address all these. Now we are coming to the addressing the key realities in managing diabetes in India, determining the choice of therapy for insulin initiation, whether it is the basal. See the four tables you can see the suitable for high carbohydrate, the other direct control of postprandial glucose, and suitable in case of delayed insulin therapy, offer convenience with total control. Is it basal? Absolutely not. Basal is not going to meet all these four demands. Certainly basal cannot do that, and a co-formulation will definitely do that, which is the right choice to address all these. See, this particular the suitable for high carbohydrate, and we also should counsel the patient not only that just we have the co-formulation that you can allow your patient to take a very high carbohydrate diet. You have to certainly curtail the carbohydrate diet, that too ask the patient to avoid the simple carbohydrates, go for the complex carbohydrates, and as far as the proteins are concerned, ask the patient to go for the proteins of the vegetable origin rather than the animal origin. Likewise, when it comes to fats, all the time you discourage the consumption of saturated fatty acids and you encourage the consumption of the monounsaturated fatty acids MUFA or the polyunsaturated fatty acids PUFA, and the total content of this particular fats, out of which 10% only can be the saturated fatty acids, and the remaining 90% must be in the form of either MUFA or PUFA. So the total control and the convenience of total control and the direct control of postprandial glucose, and suitable in case of delayed insulin therapy, also the four are met with co-formulation. They are not met with mere basal insulin. So let us now understand more about the co-formulation insulin. And now we have come to the last part of our topic, the 2-in-1 solution, innovation that suits best to the Indian reality. See, this is the diagram which shows that the insulin deglutide aspart, the world's, I said only the world's first and only co-formulation insulin is insulin deglutide aspart, and you can clearly see the insulin deglutide aspart, the blue in the middle, and on the left hand side you find I said 70% of this co-formulation is insulin deglutide, that is ultra long acting insulin deglutide, which has got the plasma half-life of 25.5 hours, and on the right hand side you can see the short acting aspart, that is 30%, and the short acting aspart is present in the form of hexamers, whereas the ultra long acting deglutide is present in the dihexamers. So though they are in the same refill, though they are in the same flex touch pen, the particles remain very separate actually. That is the point to be noted. That is the take home message. The two insulin components do not interact in the solution and in the subcutaneous tissue, thereby retaining their individual properties. So the aspart doesn't overlap on deglutide and the deglutide doesn't overlap on aspart, because aspart is present in the form of the hexamer, whereas the ultra long acting detumer is present in the dihexamer form. And what happens actually, the combination of quick release prandial insulin with the slow release basal insulin. So first of all you can see this the insulin deglutide as the co-formulation, and that is injected into the subcutaneous space, where it breaks down into the insulin deglutide in the form of dihexamer, I said, and to the insulin aspart, a hexamer, and that leads to that phenol diffuses very quickly, and the insulin deglutide dihexamers link up via the single chain contacts to the to form the long multi-hexamers, and that happens in the subcutaneous depot, and the insulin aspart monomers are released into the circulation very rapidly, whereas the zinc diffuses slowly, causing the individual insulin deglutide hexamers to deassemble releasing the monomers very slowly. And you can clearly see that the prandial part is the insulin aspart and the basal part is the insulin degludec. See, the prandial insulin aspart component of this particular co-formulation is rapidly absorbed, fast onset and short duration, and the glucose lowering action. Whereas when you come to this basal insulin degludec component, flat and stable steady state, the insulin monomers slowly and gradually dissociate, which is the greatest advantage of this particular the combination of insulin aspart and the insulin degludec. The different methods of the mechanism of action, the disintegration, the dissociation and the assimilation that leads to a very good the total control of the glycemia. And this slide is every time we have this slide because this is a gold standard slide. The profile of once daily insulin degludec and aspart, you can clearly see that the dark blue that is on the top of the curve is the insulin degludec aspart, that is given at the dose of 0.6 units per kilogram, either in the OD dose or the BD dose. And the orange is the prandial component and the green is the basal component. You can immediately see that the prandial component peaks up immediately, that is the aspart part, insulin aspart part of this the insulin degludec aspart takes care of the mealtime control with the insulin aspart, whereas the basal component which is represented in the green is completely flat and very stable. That is, you can actually say it's a peakless insulin, which results in very low incidence of hypoglycemias, especially the nocturnal hypoglycemias and the level 3 hypoglycemias, the flat and stable control with insulin degludec and the mealtime with the insulin aspart. That is what we call it as the total control. That is, it is the diagrammatic representation of the profile of the once daily insulin degludec and aspart. And the inference is insulin degludec component has got a flat and evenly distributed pharmacokinetic profile over the 24 hours, while insulin aspart component has got a fast onset of appearance and peak covering the prandial state, and the distinct prandial and the basal glucose lowering effects. And coming to the insulin initiation, either the OD insulin degludec aspart, it is compared with the OD basal insulin. That is, you give once a day the insulin degludec aspart, which is versus once a day basal insulin. So the total number in this study included were 296, the insulin naive patients with type 2 diabetes mellitus, and they were divided into two arms. The study was done for a period of 26 weeks. The 147 subjects were put on this particular insulin degludec aspart OD plus or minus the OADs, and the same 149 subjects were put on the insulin U100 glargine, the OD plus or minus OADs, and you can clearly see that there is 1.4 superior reductions in the A1C were seen with this particular insulin degludec aspart, and similar fasting plasma glucose control with 70% of the basal component. All the time you remember the basal insulin, all the time is going to control the fasting plasma glucose. The funda in treating the diabetes also is like 3 F's. Always remember, fix the fasting first. F, 3 F's that stands for fix the fasting first, and automatically you can fix the postprandial, and postprandial can be maintained with this particular the aspart component of the SIDEC and the basal component is going, the degludec is going to take care of the fasting plasma glucose, and the insulin degludec aspart provided superior long-term glycemic control when compared to insulin glargine with similar fasting plasma glucose reductions. And this is you can see the once daily insulin degludec aspart versus once daily basal insulin. The same, the left hand side you can see the graphic representation which shows the estimated treatment difference for the PPG after the major meal. There was a reduction of 57 milligrams per deciliter of blood glucose in the patient's arm who were put on this particular insulin degludec aspart. And on the right hand side you can see the hyperglycemia which leads to the oxidative stress and the hypertriglyceridemia and the antioxidant consumption and the LDL oxidation, which leads to ultimately the endothelial dysfunction and leads to atherosclerosis, and the uncontrolled PPG excursions can lead to oxidative stress and endothelial dysfunction, leading to macro and microvascular complications. And the same OD insulin degludec aspart versus OD basal insulin, the results were studied after 26 weeks. You can very clearly see on the right hand side, the study I said 147 patients were put on IDEC aspart, 149 put on this insulin glargine U100. The blue is the blue graph represents the insulin degludec and aspart, whereas the grey one shows that the insulin glargine U300. See, you can clearly see that at the end of 26 weeks, the incidence of lower risk of hypo by 27% was seen with this particular the insulin degludec aspart. And on the right hand side you can see with insulin degludec aspart, 72% more patients achieved their targets without experiencing hypoglycemia than this particular OD insulin glargine U100. So when insulin degludec aspart dosing is timed with the major meal, the basal insulin component of the insulin aspart serves the purpose of controlling the postprandial glucose excursions without leading to increased risk of hypo. That's what I mean to say. It's a complete total control. That is, preferably if you select this particular insulin degludec aspart as a once a day dosage to start with. This is called a basal plus regime actually. If you start with this, you have to start with the major meal of that particular individual. So you have to find out whether the breakfast or the lunch or the dinner, which is the major meal of that particular patient, and accordingly you have to ask the patient to take this particular the insulin degludec aspart 5 minutes prior to the major meal, so that it's going to take care of the mealtime excursions as well as the basal excursions. And again this shows the insulin degludec aspart versus basal insulin. This is a meta-analysis actually. On the right hand side you can see the changes in the mean self-measured blood glucose, and on the right hand side you can see changes in the mean self-measured postprandial glucose. And the inference is the insulin degludec aspart significantly reduced mean self-measured the blood glucose level and the postprandial glucose compared to the basal insulin. So now the Research Society for the Study of Diabetes in India and the Endocrine Society Clinical Practice Recommendations 2020, they recommend RSSDA and ESA clinical practice recommendations for the management of type 2 diabetes mellitus in 2020. IDEC ASP is recommended as choice of the choice for the insulin initiation, and the analog insulins may be used in preference to human insulins with possible lower risk of nocturnal and symptomatic hypoglycemia. However, economic considerations must be taken into account. Wherever the money is the problem, I always advise the doctors who treat diabetes to go for the biphasic premixed human insulins, which are also very, very efficacious in reducing the fasting plasma glucose as well as the postprandial plasma glucose as well as the HbA1c, provided you counsel the patient regarding the two side effects of this particular the biphasic premixed human insulin. One is the incidence of weight gain is more when compared to this insulin degludec, the insulin degludec aspart, and second thing is the incidence of hypoglycemias is more with this biphasic premixed insulins when compared to this particular the insulin degludec aspart. If you can counsel the patient how to counteract, that is, ask him to take frequent small meals. Ask the patient to take the early morning snack. Apart from the three major meal, the breakfast, lunch and the dinner, ask the patient to take the early morning snack and the mid morning snack and the evening snack and the late night snack. That will not let down the patient with the hypoglycemias. So finally, the initiate, optimize and intensify with a single device, that is, you can start with the OD doses, the insulin degludec aspart, the flex touch pen, and you can make it twice a day. And a prospective validation survey to assess the usage of premixed insulins in the management of diabetes with respect to the recommendations enlisted in Indian guidelines. In patients with the higher PPG level, insulin degludec aspart was preferred over other premixed insulin analogs and the basal insulins by 42.3% for initiation of insulin therapy. And when asked to the physicians when they would prefer using insulin degludec aspart, 61.5% responded that it can be used at initiation as well as intensification. And a practical recommendation: administer with the major meal of the day. If you are starting with the once a day, as far as the insulin degludec aspart is concerned, and initiate with 10 units of insulin degludec aspart OD with the most carbohydrate heavy meal of the day, whether it is breakfast, lunch or the dinner. Then if it is not adequately controlled, you can make this OD as BD. So the practical recommendations: the weekly titration using a simple algorithm. If the fasting plasma glucose is above the target, you increment the insulin by 2 units. If the fasting plasma glucose target is at target, so you just maintain the same dose. If the fasting plasma glucose is below the target, that is the patient is getting into the blood glucose range of less than 70 milligrams per deciliter, you reduce by 2 units. And the once daily iodic aspart dose and the blood glucose considered for titration, and for every major meal you need to monitor this particular fasting plasma glucose. And if it is given in the BID doses, bis and I doses of insulin degludec aspart dose, the blood glucose considered for titration is the pre-breakfast and pre-lunch is the pre-dinner, and the pre-dinner is the fasting plasma glucose. And coming to the summary, replacement insulin therapy should mimic the body's own insulin response as closely as possible, and great strides have been made in achieving this goal. The maintenance of glycemic targets and avoidance of hypoglycemia that have been associated with insulin analogs represent a significant value consideration, and insulin degludec aspart is a simple and convenient solution which offers a total control of PPG and FPG in people with type 2 diabetes with uncontrolled on multiple OADs. And thank you so much for patient listening. We have finished the first part of my talk. Now coming to the brief second part of my talk. Again, this is masterclass in insulins and novel insulin delivery device, the understanding the benefits. The convenient and the patient-friendly insulin pen devices of insulin deglutide aspart. I told you the insulin deglutide aspart is available in the flex stretch palm, a disposable insulin pen, and it has got a refill also that fits into NoPen 4. The flex stretch, the advantage is no push button extension, the unique injection mechanism, very low dose force is required for this, so that the elderly patients with less muscular power can easily administer this the flex stretch when compared to the NoPen 4. And end of the dose you get a click, so that you ensure that the dial has come back to 0, and it is accurate, and the consistent dosing is very much delivered with flex stretch. And coming to the NoPen 4, a durable insulin pen that is accurate dose delivery, that is ensured for at least more than 5 years, and low dose force is required to inject the insulin, and easy dose adjustment, and easy to read the dose scale, because that is a magnifying lens. Even the elderly people can see the numbers very clearly, and it has got an auto dial system. Both the things have got auto dial, that is you can reverse back. Suppose you want 20 units, you have dialed 30 units, even without wasting a single unit, you can just dial back and get back to the dose you want, and it is quick and very simple to use. And
how to use your Flex Touch pen.
Yeah, now how to use a Flex Touch pen.
Start by checking the name and strength on the label of your pen to make sure that it contains the right type of insulin. Then pull off the pen cap and check that the insulin in your pen is clear and colorless.
See, this is a video demonstration, you can clearly follow that.
Take the
Okay.
needle and tear off the paper tab. Push the needle straight onto the pen. Turn until it is on tight, and then pull off both needle caps. Keep the outer needle cap. You will need it after the injection to safely remove the needle from the pen. Check the insulin flow. Turn the dose selector to select 2 units. Hold the pen with the needle pointing up. Press and hold the dose button, and make sure that a drop appears at the needle tip. Select your dose. Turn the dose selector to select the number of units you need to inject. Inject your dose. When you are ready, insert the needle into your skin. Then press and hold the dose button until the dose counter returns to 0. Leave the needle under the skin for at least 6 seconds to make sure you get your full dose. 1, 2, 3, 4, 5, 6. Then remove the needle from your skin. Remove the needle. Unscrew the needle and dispose of it carefully. Put the pen cap back on.
See, that is how the video shows how to use the Flex Touch pen. For your convenience, I would like to go back and again, once again you can very clearly see this demo, please.
How to use your Flex Touch pen. Prepare your pen. Start by checking the name and strength on the label of your pen to make sure that it contains the right type of insulin. Then pull off the pen cap and check that the insulin in your pen is clear and colorless. Attach a new needle. Now take a new needle and tear off the paper tab. Push the needle straight onto the pen. Turn until it is on tight, and then pull off both needle caps. Keep the outer needle cap. You will need it after the injection to safely remove the needle from the pen. Check the insulin flow. Turn the dose selector to select 2 units. Hold the pen with the needle pointing up. Press and hold the dose button and make sure that a drop appears at the needle tip. Select your dose. Turn the dose selector to select the number of units you need to inject. Inject your dose. When you are ready, insert the needle into your skin. Then press and hold the dose button until the dose counter returns to 0. Leave the needle under the skin for at least 6 seconds to make sure you get your full dose. 1, 2, 3, 4, 5, 6. Then remove the needle from your skin. Remove the needle. Unscrew the needle and dispose of it carefully. Put the pen cap back on.
Yeah, I think you have seen this demonstration, the video showing how to use this flex stretch pen. But for the practical purposes in our country, I would suggest 2 more things in this. So, as per the recommendations, the needle is to be used only one time and it is to be disposed after a single use. But a country like India, where the needle costs around 12 to 15 rupees, we cannot do that every time. So this needle can be safely used for 5 to 7 days without changing that, unless you cap it very carefully so that the needle doesn't touch the walls of the cap, that it doesn't become very hard and it causes pain. That is point 1. And second thing is, the demonstration says count 1, 2, 3, 4, 5, 6. That is not sufficient. If you take it out, the larger the insulin requirement, the more time you need to retain it in the abdomen. That is, you please hold it for 30 seconds so that every droplet of the insulin goes into the subcutaneous tissue of the abdomen. So then only you leave the fingers and take out the needle and you cap it and then put the cap of the pen. So coming to the next slide, see, these are all the flex stretch is accurate at minimum, medium and maximum doses. That is, even it is accurate at 1 international unit, 40 international units and 80 international units as far as this the flex stretch and the solo star, and the 1 unit and the 30 units and 60 international units for quick pen. I think you know that the flex stretch is the insulin detimer and the insulin aspart, and the solo star is for insulin glargine, and the quick pen, it is for insulin lispro. You can clearly see that the blue one is the flex stretch and the second one is the solo star, that is for insulin glargine, and the quick pen last one is the insulin lispro. You can see the accuracy at the lowest dose. The blue one, that is the flex stretch, is so accurate that the p value is less than 0.0001. That is statistically very significant when compared to the solo star and the quick pen, and the equivalent accuracy at the medium and maximum doses with all the tested pens. So the flex stretch is very accurate. We don't use 1 unit, but okay, this is for the demonstrating the accuracy of the flex stretch. And the most patients and the healthcare professionals would recommend flex stretch. It's a multi-center open label usability studies in the people with type 1 or type 2 diabetes, outpatients, and in physicians and nurses in a crossover design. The preference regarding recommendations for others to use. So in the first diagram we saw that the 83% of the healthcare professionals they opted the flex touch, and the solo star by 10%, and no preference is by 6%. When you come to this, the second diagram, 86% of the healthcare professionals said yes to flex touch, and 7% to quick pen, and no preference is the 6%. And coming to the last diagram, 88% of the healthcare professionals said yes to this particular flex touch, whereas the vial and syringe they said 5%, and no preference is 7%. And the number was more or less like in the first the study it was the 120 people, and the second was 160 people, and the third was 120, and it is unanimously accepted that the 83 and the 86 and 88% of the healthcare professionals they recommended the flex touch, which is very accurate and very easy to use, administer the insulin. And
How to use your Flex Touch pen.
yeah, again a demo.
Prepare your pen. Start by checking the name and strength on the label of your pen to make sure that it contains the right type of insulin. Then pull off the pen cap and check that the insulin in your pen is clear and colourless. Attach a new needle. Now take a new needle and tear off the paper tab. Push the needle straight onto the pen. Turn until it is on tight, and then pull off both needle caps. Keep the outer needle cap. You will need it after the injection to safely remove the needle from the pen. Check the insulin flow. Turn the dose selector to select 2 units. Hold the pen with the needle pointing up. Press and hold the dose button, and make sure that a drop appears at the needle tip. Select your dose. Turn the dose selector to select the number of units you need to inject. Inject your dose. When you are ready, insert the needle into your skin. Then press and hold the dose button until the dose counter returns to 0. Leave the needle under the skin for at least 6 seconds to make sure you get your full dose. 1, 2, 3, 4, 5, 6. Then remove the needle from your skin. Remove the needle. Unscrew the needle and dispose of it carefully. Put the pen cap back on.
And this slide also shows the not only the flex touch, even the NovoPen 4 is accurate after 5 simulated years of use. The simulated 5 years of use of NovoPen 4 without the insulin cartridge. It is 5,475 automatic injections by a robo, that is corresponding to 3 injections a day for 5 years. The dosing included removal and replacement of cap. And dose accuracy is tested following the storage without cartridge under hot, cold and humid conditions, and a free fall from 1.5 meters onto various surfaces. And you can very clearly see this, the mean dose delivered on the x-axis, and the before and after the administration. You can see the 1 international unit and the 30 international units and the at the end is the 60 international units. That is, you can see this the before and after. It is before it is 1.02, it is so accurate, and after it is 1.05. And whereas you take this light blue which represents the 30 units, if you want to deliver 30 units, the delivered units with the NOPAIN 4 was 29.81 and 29.80 respectively. And if you take the dark blue as 60 units, the delivered dose was 59.90 and 59.72 on before and after respectively. So most healthcare professionals found NOPAIN 4 easy or very easy to use for patients. It's an open label, non-randomized observational study for 12 weeks. The healthcare professionals included in the survey was 1981, and they completed an investigator's questionnaire at baseline and after the patient had used NOPAIN for 12 weeks. And out of that, 97% of the healthcare professionals said it is very easy or easy for the patients to use, and 97% of the healthcare professionals said they would certainly recommend this particular the NOPAIN 4 for their patients. And the most HCPs rated NOPAIN 4 as very easy or easy for the patients to use at the start of the study, and the most HCPs recommended NOPAIN 4 to other patients owing to ease of use. See, the Novo Nordisk people are so kind enough, they provide this NOPAIN 4 for the doctors who are giving this pens free of cost to their patients who can easily administer, especially the type 1 or the type 2 diabetes patients. You can contact your Novo Nordisk colleague to provide you the NOPAIN 4 pens. And the cost of therapy and advantages with the pen devices, that is, the improved adherence leads to improved glycemic control, and the safety benefits, they lead to the reduced healthcare resources, and altogether they provide cost savings by improving the adherence, better glycemic control, and better safety. Use of devices is less costly. And thank you so much for your patient listening. With that, I hand over the session to my second speaker, Dr. Sepuri Thirumal Devi.
Thank you, sir. Thank you for your